Hello, I'm Dr. John Kruse, and today I'm going to be talking about stimulant dosages and the honeymoon period, where the honeymoon period is the initial best reaction many people ever get to stimulant medications. That's led me to open up to a bigger topic of stimulant medication dosages and tolerance. I'd be delighted if this is a discussion rather than just a lecture, so if there are questions you have while you're watching this, please type them in and I'll get to them at the end. And I will be talking somewhere in the 10 to 20 minute range. So I'm going to launch right into it. So there's lots of attention in online forums and other places, and when people come into the office, I'm focusing on, is this dose a big dose of stimulant or is this dose a little dose? I was reading on Quora yesterday, someone asking whether they could be possibly having a response to just 2.5 milligrams of Ritalin, and there was a chorus of voices saying, no, that's impossible, you couldn't be responding to that. I think that's pretty inaccurate. So what I mean by that is, for all of our medications, stimulants aren't an exception. There's pretty close to a normal distribution of curves. So most people are going to respond to a dose close to the average, but there's going to be some people who need bigger doses, some people need smaller doses, and at the ends, very small numbers of people who need really big dosages, really small numbers of people who will respond to a tiny, tiny dose. So yes, your odds of being one of those people responding to a tiny, tiny dose or a ultra big dose are low, but someone's going to be there. So saying that nobody's going to respond to that low dose is just simply wrong, or that a huge dose is inappropriate for everyone is also wrong. And this is a big issue for me because insurance plans often put limits on dosage levels, and unless the FDA requirements for the drug cover the range that your patient's in, they'll just say, oh, there's no documentation that this works. So you can document out the wazoo that for this individual patient, they're using it safely, they're not having side effects, it's working well for them, and that lower doses didn't, and the insurance companies don't care and can reject that. And again, that's based on the mistaken notion that the average dose or the FDA approved dose is the dose that's going to work optimally for everybody. Clearly not true. The other thing that I saw a lot of, I would argue, misinformation on the online forums was that people responding this, ADD is really mild, maybe you can, or for people who are writing in about really big dosages. So online, and I'd say in my office as well, people's expectation is that there is a very strong correlation between body size and, not between body size, between severity of your symptoms and the dosage you'll need, with big people needing a big dose and small people needing a small dose. And I have not found any studies about this one way or another, but most of the experts talking will say, at best, there's a very poor or weak correlation. So there's people with severe ADD who do well on small doses or who can't even tolerate the stimulants, and people who have milder versions of it, but who seem to respond well to bigger doses. So severity of symptoms is a poor indicator of dosage. Gender, body size are both poor indicators of dosage. Why would that be? Shouldn't a bigger person need a bigger dose? And part of the answer is that most of these ADD drugs and most of our drugs in general are chewed up by the liver, and the biggest factor determining what dose is going to work for you, or actually what oral dose in your mouth is going to equate to a certain blood level, is how active your liver enzymes are at metabolizing or breaking down the drug. And even though there is a big range in body sizes, there's a much smaller range in liver sizes, and there's a smaller range in how quickly essentially your blood passes through the circulatory system and gets scanned by the liver and exposed to enzymes that may be chewing it down. So again, but within those liver enzymes, and this is a big component of it, is genetically determined. Some people's enzymes are really good at chewing up drugs, and some people's enzymes are really poor at chewing up drugs, and unless your liver is so sick that it's not functioning, which can cause big problems with dealing with drugs and other things, outside of that, again, the size of your liver isn't the issue, it's the efficiency of your liver enzymes chewing up drugs. So that's sort of a generic description, but why body size, severity of symptoms, gender don't seem to correlate well with dosages. So the other aspect with the stimulants where this is particularly relevant is the stimulants, even though they do have some potential for dangerous side effects, are actually a pretty darn easy set of drugs to titrate the right dose. And what I mean by that is with the stimulants, generally you're seeing pretty much all the good effects you're going to get and most of the likely common side effects right up front, right within minutes to hours of taking the dose. So you know, are you too jittery, are you too revved up? Has it taken away your appetite? Can you, on the negative side of things or on the positive side of things, are you able to focus? Are you able to attend to tasks? Are you able to initiate tasks that you were reluctant to approach before? You know that right away. With their antidepressants, you might need to be on a medication for 2 weeks, 3 weeks, 6 weeks before you have any clue that what you're putting in your mouth is actually helping with your depressive symptoms. So antidepressants and many of our other drugs are harder to titrate or calculate. So with the ADHD medications, we should be focused on what's functionally benefiting you. So if it's not not producing any benefits, there's no point in taking it. And if it's causing adverse effects, then we have to weigh the balance between whether the benefits outweigh the negative effects. But again, usually we can adjust and figure that out pretty quickly. Determine that pretty quickly and adjust either up or down to get either a bigger benefit or to reduce side effects which are undesirable. Now, when I looked at how common tolerance, people often is one of the components of addiction. Tolerance is not the same as addiction. Tolerance is a sort of cleaner, simpler concept that just means for the same effect, you need bigger doses over time. Or you need a bigger dose today to get that same effect than you needed at some previous earlier time. So again, most people who wind up with addiction problems with these or other drugs have developed tolerance, but you can certainly be tolerant without being addicted. And there are several other components to addiction besides tolerance. So I was trying to find rigorous studies looking at tolerance and the stimulant medications, and I'm not saying they're not out there. I could not find much actual research. There were lots of expert recommendations and compended assessments of bodies of experts on and it was interesting because there were two very different things I found. So one is that in the ADD literature, most of the experts say something like, there may be some initial titration to find out the optimal dose, but most people, once they find an optimal dose, continue to do well on that dose for years, and that dose tends to be stable. In the addiction medicine research, what jumps out everywhere is that with the stimulants, most people develop tolerance very quickly and need bigger and bigger doses to get to the same effect. Now, one important difference here is with the addiction group of experts, and again, these are not rigorous studies, these are expert opinions. They're talking to the euphoric, the mood lifting, the joyous, elated, omnipotent feeling that stimulants can produce. And in the ADD literature, they are focusing primarily on what are thought of as the cognitive, motivating, getting your work done, staying on track aspects. And certainly we know lots of drugs that cause effects in multiple different systems in the brain or in the body. You could develop tolerance to one set of side effects, but not to their benefits, if we're going to classify reactions in that way. So a classic example is in the antidepressant medication field. Most people who have nausea starting out on an SSRI, and only about a quarter of people do, but of that quarter, almost all of them within 4, 5, 6 days, nausea goes away and isn't an issue. On the other hand, antidepressant benefits don't go away within 4 or 5 days. In fact, they're not even showing up within 4 or 5 days. But again, you can get tolerance to some effects of a drug and not to all. So hard data on rates of tolerance among, and particularly now to the beneficial effects. Again, I'm not saying they're not out there. If you know of sources or have seen studies, please send them to me, but I couldn't find any hard data on how likely tolerance is to the beneficial effects, separate from sort of some initial dosage adjustment period. And I'll be getting to the honeymoon period in just a minute. And certainly in laboratory animals and from other medications and here there's some research in the laboratory situation on tolerance to stimulants, we think there's at least 3 big variables that can help decrease the likelihood for tolerance over time. So one, in general, it seems that lower doses are less likely to provoke tolerance. But again, if your body needs a higher dose to get to the same blood level, maybe that is a risk factor for putting you running into a problem. So again, it's not clear whether lower dose really means lower oral dose or lower blood level dose. And again, those could be discrepant based on how efficient your liver is. 2 is there's multiple claims that long-acting drugs, and particularly with the stimulants, we have immediate release forms and slow release forms, that the slow release or long-acting drugs are less likely to cause tolerance, and it may be sort of going that the dopamine and or other neurons going on and off receptors quickly may be a factor in tolerance, and if it's sitting there stably or available for a longer period of time, that may reduce the likelihood of tolerance. I have not seen, again, I'm not saying they're not there, but I haven't seen whether in the real world we actually can detect that. And then the other strategy for reducing tolerance, and most patients at least have some experiences with this, is drug holidays. So the claim has been for years, and again, in the laboratory situation, we can see this, that taking a few days off tends to reverse some effects of tolerance or prevent it possibly from happening. And many people will notice, particularly if they take their medicine on weekdays, but not on the weekend, when Monday comes around, they'll say one of 2 things, not always, but wow, this feels stronger than it did, at the end of the week, Thursday, Friday. Or, and this may be saying the same thing, that it doesn't feel stronger, but I'm functioning better on it, or I can more clearly detect a difference or a benefit to it than I could towards the end of the week. So again, one of the things I've looked for over the years and have not seen for years, experts have said keeping kids off of the medication on the weekends would decrease the risk of tolerance and a host of other addiction problems. I have not found a study that actually looked at that, and for the last few decades, at least in America, kids have so many weekend activities, whether it's piano practice or soccer practice or extracurriculars that they need and or want to be on top of and focused on, that many more children seem to be taking medications every day of the week than maybe a generation ago. And similarly with adults, many adults do find benefits of the stimulants outside of just the production-driven, cognitively focused use of the stimulants, which we sort of focus on. They're good for schoolwork, they're getting good for productivity, but they're also good for improving communication. They're good for emotional regulation, improving emotional regulation in people with ADHD. So there are many compelling reasons for people to be taking them on the weekends as well as weekdays. So jumping more specifically to what the topic today is supposed to be, and that is the honeymoon period. And that's the observation that many people's very best, very most powerful response to stimulant medications is their first few weeks on the medication. So it's like, finally, something works, something helps me perform and behave in the real world. I feel more like a, quote, normal person. And then some of that effect wears off, usually not all of it. And even if there's dosages adjustments, people never quite capture that idyllic honeymoon period. And in the literature, there's 2 different arguments that people put forth, and my guess is for many people both are at play. Some argue that this is a purely physiologic phenomena, that is, we're dealing with drugs that are essentially making more dopamine available because they're dopamine blockers, and with Adderall, amphetamines, forcing more dopamine out of the receptor, out of the end of the nerve synapse into the receptor space, into the synaptic space, that the downstream receptors then upgrade over time, and that's why you're not seeing the same benefit you initially did. That may well be part of it. That doesn't quite explain why. Well, why then wouldn't giving a bigger dose, because then you'd still be making more dopamine available, and even if there's up or down regulation of certain sets of receptors, it should be able to flood those or have the same biological impact that a lower dose did on a smaller number of receptors to begin with. So again, it may be physiologic and have to do with up and down regulation of different receptor systems. There's also a component, I think, in most people that is psychological. And what I'm saying here is that if you've never had anything that helped for your ADHD, if you've never had any benefits or felt like you were continually frustrated and doing what it seemed like other people could do with much less effort, and you finally find something that's working, and there's a euphoric effect to these medications, it feels delightful. And even in those early days, you are almost certainly not having a brain that's free of all ADHD. You're still forgetting things. There's still some distraction. But in your individual state, you're feeling you're doing so much better, you don't pay attention to those. As time goes on, you become more aware of, yes, I got my business reports done every day this week, but I did forget to turn in something after that meeting, or you become more aware of, yes, I'm doing better, but yes, I was still missing things. And again, maybe if the euphoric effect of the stimulants is something you became tolerant to, and the cognitive benefits, as it were, have remained stable, that could also explain some of that honeymoon effect. So I'll race through the last 3 minutes. One of my questions was, since I didn't find any data, again, I'm not saying it's not out there, for tolerance to stimulants, I decided to look at my own practice. And my expectation was that most of my patients, my experience is once they're on a steady dosage, they tend to do well. Some do need to go up over time, some need to go down over time. My prediction was that probably 70% of my patients were on a stable dose, and maybe 20% were needing to upgrade, and maybe 10% were needing to downgrade over time. So I actually crunched the numbers. I had more than 104 patients in the last year. And what I looked at were people who had already been on medications for a year ago. So they were already stable. We're not talking about a honeymoon period. We're not talking about initial titration. A year ago, they're on a stable dose. And then I just looked at where a year later, are they now on dosages? And 80% of them were on the same dose they were on a year ago. Not too different than what I predicted, but more stability than I actually expected. Only 7% of those patients had gone up on the dose, so a smaller percentage than the 20 I had guessed. And a full 13% had gone down in their dosage. Now, part of this is, unfortunately, the timing is COVID affected. So this year has been the COVID year, and while anxiety is ratcheted up, I've recommended to a number of patients that your stimulant dose probably should go down if you're feeling more anxious, because many of the same chemicals that the norepinephrine, epinephrine, whose other names are adrenaline, noradrenaline, that are released during anxiety, are some of the same that are boosted by some of our stimulant medication. So you don't need a double dose of your medication and anxiety boosting you up. The other factor is that my expectation, and what I tell people about, is that my expectation is that you're going to be on that the dose will be stable, and whether that either leads them to a stable dose working better for them, or the negative angle on that would be that I am discouraging people who really need more from asking for more help, although again, the fact that at least some people did seems to reduce that as a possibility. But again, I'm not pretending this is generalizable to the whole world. This is my experience with about 100 people. And again, most of them who were on a stable dose a year ago are on that same stable dose. So that's, again, reassuring to me that most of them aren't getting tolerant to the beneficial cognitive attention, productivity with work issues getting done. So I'm not seeing any questions. If you want to type in questions later, I can answer them. This will also show up on YouTube in a few days. And next week's topic is going to be sort of more tip or practical oriented. It's called Forgetting Medication Dosages. What can you do about it? Strategies to prevent it. So I see one note, but it's not really a question. So I will be signing off. Have a good and healthy, happy week. And I'll see you next Friday at